Good evening, everyone. Welcome you all to Oncology Classroom evening session. Today, we are going to discuss an interesting topic, breast conservation and functional preservation in breast cancer. This lecture will be delivered by Dr. Ramesh Sarin. Dr. Sarin is one of the senior most breast surgeons working in this country. And at present, she has been working at Indraprastha Apollo Hospitals, New Delhi as Senior Consultant Surgical Oncologist and Breast Cancer Specialist. It's a real privilege to all of us to be here today and listen to this beautiful lecture. On behalf of Oncology Classroom, I pay my sincere thanks to Dr. Sarin for accepting this invitation and be with us. Without wasting any further time, may I now request Dr. Sarin to please take over this session and start her lecture. Thank you, ma'am, once again for being with us.
Breast surgery and mostly on breast conservation and preservation of function. It's my pleasure and privilege to present to you what I think is a good breast conservative surgery. The next slide. As we all know that breast cancer is number one frequently diagnosed breast cancer in the world. 1.6 million new cases are identified the world over, and in India the incidence is 1.6 lakhs, which is 1/10 the incidence in the world, and annually 50% of our patients die, and the more number die in the villages or in the rural areas than in the metros and the urban areas. And it's expected, because of our lifestyle changes, that the cancer will double by year 2026. So we're going to see a lot of breast cancer, and I think it's a good time to be aware of what is the correct surgical treatment, which majority of the early breast cancer needs the breast surgery. So this slide was presented by Veronesi a couple of years ago, and it holds true today also, that we have shifted from maximum tolerable treatment, which used to be radical mastectomy, to minimum effective treatment. And the minimum effective treatment is a breast conservative surgery or just excision of the breast. Then we moved away from anatomical concept of cancer spread. We thought that the breast cancer spreads in an anatomical way from breast to the lymph nodes, then to the system, but that's not so. We now know that the biological concept that the breast cancer can be metastatic without going into the lymph nodes. Next one. Also from very aggressive radio and surgery, and in fact chemotherapy, we have now moved over to targeted conservative treatments, and one of the conservative treatment is the breast conservative surgery that you're going to hear today. So the first trial of a breast conservative surgery was done in 1967. So it's almost 45 years that we started the first randomized trial of breast conservative surgery, called the National Surgical Adjuvant Breast Project B06. And this one, they had, the last slide still, they had the last slide. They had about 1,600 patients, and they were randomized to mastectomy versus the breast conservative surgery, which included the radiation therapy. And now we have 20 years follow-up of this trial, and we found, the next slide, after this, there have been many, along with this, actually at the same time, we have many studies from the EORTC. We have the Danish study, we have the national NCI study, and we have the French study, as well as the National Cancer Institute studies with varying number of patients and with varying number of follow-ups. You can see the follow-ups here from almost 6 to 20 years for the first trial, and we now know that the local recurrence rate may be slightly higher, but not so in the last 5 to 10 years. And the overall survival of patients undergoing mastectomy versus the breast conservative surgery and radiotherapy is more or less the same. I think all of you know that the breast conservative surgery is here to stay. The next one. So, breast conservative surgery has become the standard of care in early breast cancer, and we will discuss which patients are suitable for wide lumpectomy and radiation therapy. The next slide. Um, so, what is a breast conservative therapy? The breast conservative treatment is a complete removal of the breast cancerous tissue with a concentric margin of surrounding healthy tissue. And I'll tell you how much healthy tissue is needed, followed by radiation therapy to either the whole breast or to the local involved area. That also, you know, that we can give them localized radiation, and the aim is to achieve a cosmetically acceptable conserved breast. So that's another important thing, that we, whenever we consider to do a breast conservation, we must make sure that the breast left behind will be cosmetically acceptable. The next one. I brought these slides over here to let you know that 3 years ago, this data was presented from the Danish Cancer Registry, which is all over the world. And they had actually a large number of patients from diagnosis from 2000 to 2004, and this is the number. This is the patients that they collected, and then they had a follow-up for 15 years. Patients were all T1 to T2, N0 or N1 stage, and they were treated either with breast conservative surgery or mastectomy in all the Dutch hospitals. And there was no macroscopic residual tumor on resection. The next one. And they had a long follow-up, and they had 37,207 patients. Now you can't have more number than this, out of which 58.4% had the breast conservative treatment. Though this was a retrospective study, and hence there was some bias that the patients were younger, the tumors were smaller, well differentiated, unifocal and ductal tumors. They were localized in either inner or outer quadrant, and they had less of hormonal therapy and less of lymph node dissection. Though there was a bias, but the overall, next slide, the overall results of the group that underwent the mastectomy in the red line versus the blue interrupted line who had breast conservative surgery, you can see that 10-year overall survival was better in the group doing the breast conservative surgery. So if my patient is fit for a breast conservative surgery, I give them this example and say, whatever myths you heard that the mastectomy gives you better survival, that is not so. And there have been many explanations why breast conservative surgery people are doing better than the mastectomy. The next slide. So that was 10 years overall survival. So as we said, median overall time was 11.3 years, and it was statistically significant to the value of less than 0.001. So I think though a retrospective study, there are lots of confounding factors, but on the whole, this does give us a lot of confidence that if breast conservative surgery is done in the proper way, the patient has a similar overall survival and overall distant disease-free survival. The local thing we'll get into. The next one, the next slide, the next one, next slide. So now, before, as I said, can we have the slide before that? Maybe the slide before that. Okay, the next slide. So, what are the clinical and mammographic evaluation before we say that a patient is fit for a breast conservative surgery? You have to measure the size, including the speculation. If you look at this, if you look at the first photograph, you got to take the size, including the speculations, and you got to determine whether it's multicentric, the third photograph, and you got to see whether there are microcalcifications, and one may have to do magnification compression views to get to assess the entire area that is cancerous and that needs to be removed. Sometimes we do use an MRI, though it is not routinely used. The next one. So, as I said, in suitably selected patients with T1, T2, and occasionally T3. So, even if the tumor is 5 cm, but the breast is large, and even if the lymph nodes are involved, and even if they are like you think is involved up to 3 or 4 lymph nodes number, of course, heavily infiltratory axilla can also undergo breast conservation, but it's like little bit, you want to start chemotherapy faster and all that. So T0, N0, N1 can undergo breast conservative surgery with radiation with equal and maybe better survival than mastectomy. But most important criteria is to get a negative margin of the lumpectomy specimen while achieving good cosmesis. So a negative margin, and I'll tell you what is a negative margin. Next slide. Before the negative margin, I just want to tell you there are some absolute contraindications and there are some relative contraindications. I'm sure you all know that, but just to re-emphasize that multicentric disease is more than one quadrant. Usually we think it's a contraindication, though I'll tell you in my next slide what is the latest thinking. Diffuse malignant appearing microcalcification involving more than 20% of the breast. If there are persistent positive margins, if you've gone in for a surgery and your margin is positive, you re-excise and the margin is again positive. And if you think the third re-excision is possible, you do that and the margin is positive. Obviously, there is some micro or DCIS at the margins that you have not picked up, and then patient should be convinced for a mastectomy even before you start the surgery. I mean, if a patient is for a breast conservation, but you have to take a consent for a mastectomy also. Also, you must see that the patient is able to get radiation, and especially during pregnancy, if a radiation is needed in the second or third trimester, obviously this patient is not fit for a breast conservation. And if a patient has received previous radiation, you know that you can re-radiate if there is a local recurrence, but that amount of radiation that goes in is much smaller than the radiation you need to get. The relative contraindications are scleroderma or systemic lupus erythematosus, which is a collagen disease. So you have to see if it's been under control and it's been controlled for a long time and it's a young patient. You could take you could do a breast conservative surgery. And if there is unfavorable tumor size, as I said, if the tumor is 5 cm or even 5.5 cm, the breast is a good size. Or if you can do oncoplastic surgery, this is only a relative contraindication and not an absolute contraindication. The next one. These are the various examples that I just told you, that big size tumor, multiple quadrants being involved with a multicentric disease. There's been a large microcalcification involving a large area over here, and again a multiple tumors over here. Here, if you think the amount of breast tissue excision is more than 20%, then patient needs some kind of oncoplasty or patient needs a mastectomy. The next one. Now this, as I said, is a multifocal tumor. Multifocal means it's multiple areas in the same quadrant. This patient, if she is very keen for a breast conservation, it can be done as long as you encompass removing the entire tumor bearing area. So in the last 2017 St. Gallen's conference, 66% of the people voted in favor of breast conservative surgery, while 33% voted against it. So it's a matter of personal choice between you and the patient. The next one. As you already know, I don't have to go into the details, that the radiation does reduce the recurrence rate locally in the local area, and this is statistically significant. In node negative, there is reduction by 16.1%, and the 5-year gain in people with node positive is almost 30%. So if you have a node positive patient undergoing breast conservative surgery, the patient should be counseled for radiation even before the surgery is undertaken. The next one, and this one is the overall survival and mortality. If you do a radiation, as against no radiation, um, the recurrence rate is also less systemically. That means overall mortality is much better or less than if you don't give the radiation. And the 15-year gain is almost 5.4%, which is as good as giving a chemotherapy. You know, chemotherapy also gives you 5% overall better survival. So radiation has to be stressed to anybody undergoing a breast conservative surgery. The next one. Now, do all patients treated with breast conservative surgery require radiation? The answer is no. Only select group of answer is yes, they do need radiation, except a very small group of patients who is like older age group with comorbidities, have a good histology, are small tumors and are node negative. They could be spared the radiation considering all other factors. The next one. Also, if a patient is going to go for tamoxifen, and as I said, with comorbidities, the next slide, the next one, you can see that the next one, this was a trial where they gave to this group, they gave tamoxifen to one third, tamoxifen and radiation to the other, and radiation alone to the third group. And you can see that tamoxifen and radiation, the local recurrence rate was 1% as against 6% in radiation group. That means the tamoxifen is doing something good to these patients. So if it's a good histology of ER/PR positive patients, and the patient with comorbidities and patient is and or old, you could just give them tamoxifen, because that one will reduce the local recurrence rate. The next one. So now, what is a negative margin? There's been a lot of controversy as to the negative margin in the literature at various conferences, and lots of description have been given. But now the consensus in majority of the breast surgeons or the breast oncologists is that a negative margin is defined as no ink on the tumor for invasive carcinoma. So when we take the specimen out, I'll show you the specimen, they ink it all around. In fact, they should ink it with different colors, but even if they ink it black, and that black area, a section is taken, if there is no cancer at the black area, it is considered as negative margin. So you don't need to have 1 centimeter margin in the pathology department. Though when we remove the tumor, we remove with 1 cm margin. So the excision is done from a palpable margin to 1 cm normal tissue. But in the pathology, if there is no tumor at the ink margin, it is considered as negative margin. Now the thing is that if our patients don't come for a regular checkup, and our patients are not very amenable for redo surgery, so a lot of people in India and in the other developing countries feel that we should have a 2 millimeter margin around the tumor area, because our patients think that we done something wrong if a margin comes as positive. So we like to have 2 millimeter in India, but the world over, negative margin is defined as no cancer on the inked surface. The next one. Now, do we need? There was also a debate couple of years ago, 4 or 5 years ago. Do the worse biology, the triple negative breast cancer and the lobular cancer, because they are of a worse prognosis, do they need bigger margins? And there's been a lot of debate on that. Next slide. But now the debate is also settled over there in that same Gallant's 2017 conference, and Morrow et al. From the Memorial Sloan Kettering reported on so many patients who underwent breast conservative surgery, and they in their presentation said that wider surgical margins did not improve the local recurrence rate in this subgroup of patients. So if you have wider margins, I'll just come back to you what margin should be there. But in fact, the margins are again no tumor at the ink margin. The wider margins did not improve the local recurrence rates. The local recurrence rate at 60 months for patients with margins less than 2 millimeter was 4.7%, and 3.7% for those with margins more than 2 millimeter. So even less than 2 millimeter, the margin, the local recurrence rate was not much more than if you took bigger margins. And at the end, the conclusion was that the triple negative breast cancer and HER2 positive tumors had a significantly higher risk of ipsilateral breast tumor recurrence compared with patients with other subtypes. The next slide. The reasons are, the next slide, that local failure, the ipsilateral breast tumor recurrence occurs as a marker of aggressive biology. It's that the biology is aggressive, it's not the tumor margin. Because the biology is aggressive, that is why the local recurrence rate is higher in these patients. And they said that there was a 40% decline in the ipsilateral breast tumor recurrence in patients with HER2 positive tumor who received the anti-HER2 agents. Like I showed you the tamoxifen. So if HER2 positive patients receive the anti-HER2 agents, there is a 40% decline in ipsilateral breast tumor recurrence. The risk of ipsilateral breast tumor recurrence varies by subtype on the results of many studies, irrespective of whether you do mastectomy or breast conservative surgery. So it doesn't matter whether you do this or you do that, the local recurrence rate is higher in such groups. So there is no justification, according to them, for wider clear margin than no ink on the tumor, even in such patients. But as I said earlier on, that in India we would accept 2 millimeter margin as a good margin. Having said that, if one margin is 1 millimeter or no tumor at the ink margin and the rest are 2 millimeter, you don't have to go in and re-excise this tumor, because you have to consider the other biology, you have to consider your radiation friends, you got to consider what kind of radiation you have and what kind of boost you can give. So the re-excision is decided in a tumor board settings. Next one. So that is about the breast surgery per primum in patients who are early breast cancer. Now, if a patient comes to you in a bigger size tumor, or the tumor is 4 cm but the breast is smaller and the patient is keen for a breast conservation, these patients could have a neoadjuvant systemic therapy. And I must tell you today, in fact, even a 2 centimeter and a 3 centimeter triple negative or HER2 positive tumors, we put them for neoadjuvant chemotherapy because there are lots of advantages of giving them neoadjuvant. The next one. Now, if a patient is going to go for a neoadjuvant chemotherapy, whether it's triple negative or HER2 positive or even hormone positive, but advanced tumor, locally advanced tumor, if you are going to do neoadjuvant chemotherapy, you must put in a clip. You must put in a marker in the tumor, and the marker should be in the middle of it. And 90% of the panelists agreed in favor of putting a marker. But the controversy exists whether you should put in the marker at the same time as the core biopsy, or should it be when the tumor becomes 2 cm. Our patients present at a later stage, locally advanced, 6 centimeter tumors. So the clip may not be in the middle if it is a 6 cm tumor. So we wait for 2 or 3 cycles of chemotherapy. When the tumor becomes smaller, we put in a clip. The next one. Now, when you put a patient on a neoadjuvant chemotherapy, you just see this one. This is the tumor. It can respond in 3 ways. Just go down. Yeah, right. The first one is that the tumor has completely disappeared and there's no residual disease left. The second one is that the tumor has reduced, but it's become smaller and it's concentric. It's concentric. The third one is that there is a response which is not concentric, but its response is patchy, and so you have a tumor left behind in patchy areas, and the size is the same as the original tumor. Now, one should actually know after the neoadjuvant chemotherapy is completed what is the kind of response, and for that one needs to do a very good high quality ultrasound. We actually at Apollo, because patients can afford it, we do an MRI before and after the neoadjuvant chemotherapy, because we want to be very sure that we are not leaving any tumor behind when we do surgery after the neoadjuvant chemotherapy. The next slide. So now the question is, as I said in the last slide, I should have told you that the amount of excision depends on the amount of tumor left behind. It does not depend on the amount of tumor or the size of tumor that was initially. It doesn't depend on the old borders, it depends on the new borders. Obviously, in the third scenario, just so the third scenario, the size has to be like the original tumor with 1 cm around. So if you can't feel the tumor, you got to assess by your J wires and other areas to be able to take the whole tumor out. The next one. Now, do we need? Now, this is the kind of tumor where you need to see that your margins are clear. So, do we need intraoperative margin status evaluation? In the first scenario where we are doing breast conservative surgery per primum, we don't really need to do any margin assessment. But in this one, in this one, we do need some kind of a margin assessment, and that there are 2 or 3 kinds of margin assessment. There is intraoperative frozen section, but as you can imagine, the intraoperative frozen section from all the 4 areas and from the base 5 areas, the pathologists are going to take time, and it cannot be 100% sensitive or specific, and hence one has to consider the cost effectiveness and optimum resource. There are newer methods of frozen section by freezing the tissue, and sometimes we only do cavity shaving. But we at Apollo Hospital look at the MRI, and if our MRIs are very good, and if our MRI is saying it's a MRI and the ultrasound is saying it's a complete disappearance, we just put in a J wire at the clip and excise around it. Otherwise, whatever tumor is left behind, we excise that. We look at the cavity grossly, and if we find anything suspicious, we send it for frozen. Otherwise, we don't send it for frozen, because we have assessed the tumor, the patient before the surgery with a high quality ultrasound and high quality MRI. The next one. So the consensus is not there whether we should do the margin assessment at the time of surgery, or whether we should do it only at the paraffin sectioning. The next one. So now we finished the neoadjuvant chemo and the per primum surgery. We come to the controversies in the treatment of ductal carcinoma in situ of the breast. Can we do a breast conservative surgery in this? 20%, 20% of all screening mammograms in America are reported as DCIS of 1 cm or 2 cm. So imagine they have 20% DCIS of very small size. Over here, the DCIS can be detected either when somebody has gone for an incidental mammography, or if um, if there is a palpable mass with the DCIS. Sometimes you can have a palpable mass with the DCIS. Now, mastectomy is done in 30% of the patients, and breast conservative surgery with radiation, breast conservative surgery without radiation, and if the Van-New index is low. Local relapse rate does happen with just breast conservative surgery to the tune of 20 to 30%. But if you add radiation, the local recurrence rate reduces. And as I said, we are more liberal with radiation because our patients never present with 1 cm. They are always 2 or 3 cm. So it depends on the size, the age of the patient, and the margins negativity. 50% now, if you have DCIS, there are some bad prognostic features like necrosis if the margins are not adequate. So 50% of them, if they relapse, they are invasive cancers. So these are curable cancers, 98% cure rates. So we should not really get a relapse in these patients because when it relapses, it's invasive. The free surgical margin is the key, and in this one, the surgical margins internationally is recommended as 2, but we would like it to be 10 millimeter margins um, in if we are going to do a breast conservative surgery. The next one. Next slide. So, as we said, histological report shows incomplete resection and margin involvement more frequently in DCIS surgery. That you can imagine yourself that DCIS is not a palpable tumor. You can't palpate it. You only see it on a mammogram. You don't even see it on ultrasound that well. So, if you have to do the margins, how much margin to take out, you got to put in J wires under mammographic stereotactic, and that's not an easy job to do. So it's difficult at the time of surgery to see whether you have taken 1 cm normal breast tissue or not. So some kind of radiological localization is necessary, like the wire localization, as I said. And if it's a small size DCIS, there is something called a roll method, which is radio guided occult lesion localization. Here we inject technetium 99 in the um, middle of the DCIS lesion, and then with the technique with the gamma camera in the OT, we find out where is the technetium, how much area the technetium is picked up by the gamma camera. We excise the whole thing, and that's a roll method. And you can also put in radioactive seed localization, but then you need to have equipment in the OT where the radioactive iodine seed can be localized. All methods are equally reliable. We do the wire localization method in DCIS patients. Next one, requiring breast conservation. So after we taken out the DCIS with a margin, as I said, with a J wire and a margin, then we do a specimen photograph of the margin, because this is what we take back to the mammographic room, do an x-rays to find out if the entire microcalcification seen in the pre-operative x-rays has been taken out or not, like over here. So the margins are all clear. This is how we find out that we think that the margins, we are beyond the DCIS. Next one, frozen section is not very helpful. So negative margins halves the IBTR. As I said, 2 millimeter margin is the standard for the Western people, but we like to have more than 2 millimeter because your Van new index actually takes the size of the normal breast tissue around the DCIS. The next one. So far about the breast conservative surgery, neoadjuvant, in ductal carcinoma in situ, and per primer. Now we come to functional preservation, which is the shoulder preservation or the nerve involvement, the second intercostal nerve damage, and also the lymphedema, which is a functional part of the quality of life of the patient. So now coming to the node, sentinel lymph node biopsy concept came along many years ago, again 2008, almost 12 years old, where we learned that a certain part of the breast tissue drains into a specific lymph node. And if the first group of lymph nodes are not involved, there is only 5% chance that the rest of them will be involved. So, and if the first group is involved, then you do not know how many more will be involved. So, if we have a tumor over here, it drains into this group. If we have a tumor over here, drains into this group. So, if we have a method to localize the tumor and we have something that can travel by lymphatics to the lymph nodes, we will know, and if we can take that lymph node out, you all know what is a sentinel lymph node. Next one. So this one is a radioactive iodine injection around the nipple or areola or around the tumor, and technetium 99 is given. And also a blue technetium 99 can be given either the day before the surgery, within the 16 to 18 hours of the surgery, and the blue dye is given around 8 to 10 minutes before the surgery. So both the radioactive technetium tagged with human albumin or sulfur and the blue dye, two methods go to the first group of lymph nodes, and with the gamma camera we pick that up. The next one, here is the technetium being given around the tumor, and here they do a SCINTIMAMMOGRAPhy and they tell us that yes, they can see the tumor. Seeing the tumor does not mean that it's involved with cancer. Seeing the tumor, seeing the lymph node means that we can dissect it. It is seen, and the gamma camera should see it. It's only telling you that the lymph node is available or easily dissectable. It does not mean that it's involved with tumor, which many people think that if it is seen, it means it's involved with tumor. So they do various pictures of a SCINTIMAMMOGRAPhy and tell us if the lymph node is seen or not seen. If it is seen, it's almost always recoverable. If it is not seen, even then 50% of the time we can recover it, because if a patient has a lot of fat in front of it, we may not be able to, or the counts may be very low. By the time they come to the OT, the counts become better, or the blue dye may go over there. The next one. So this is how we do the sentinel lymph nodes, and as you can see in the axilla, there is only 2 to 4 centimeter of the incision. We use this is the gamma camera. We use the gamma camera inside and pick up the radiation counts, and when the counts are a lot than the surrounding tissues, we take out that lymph node, and after taking that lymph node out, we see the counts again in the remaining cavity. If the counts are less than 1/10 of the counts in this, supposing this count is 100 and this is 10 or 11, that means no other hot lymph nodes are present. So it doesn't depend on the number of counts. It doesn't depend on the 100 or 1000. It depends on 1/10 of the counts in the hot lymph node. The rest of the tissue should have less than 1/10 of the counts in this one. So that is considered to be the proper lymph node retrieval. The next one. And so pathological examination is like we are doing it according to the international standard. If the lymph node is 1 cm, of 1.5 cm. It's cut in the middle, and both sides are taken for a frozen section. And on the frozen, they take about 40 minutes, and they let us know whether there is tumor in that or not. The next one. I just wanted to tell you our data is consistent with the rest of the world, saying that our sentinel lymph nodes are as good recovery, identification, and the positivity rate as the rest of the world. So we had presented this data in 2016 in 447 patients with the sentinel lymph nodes, and all patients with T1, T2, T0, TIS, and few with T3 and N0 patients were undertaken for sentinel lymph node biopsy. The next one. So this is to be done in clinically negative lymph nodes, and now we do even ultrasound, and it should be ultrasound negative also. If the ultrasound says that there may be a positive tumor, we stick a needle in and find out if there is tumor in the lymph nodes. If the cytology of the lymph node comes as positive, we usually do not do a sentinel lymph node. So it's both clinical nowadays, even the ultrasound. So after 447 patients, we did a validation study in 218 patients. You actually don't need that many, but because it was the beginning of 2008, so we did a large number where we did sentinel lymph node and dissected the axillary lymph node. So this is the group that I'm going to present to you. What was our identification rate and false negative rate. Next one. So you saw in T1, we had 36.9% of the patients were T1, but even 51% of the patients were there in T2, and a small number even in T3 and T0 and TIS. So the next one, it's now the mean number of lymph nodes dissected were 2.5, though the range was this, but median was 2.5. This is the same as the rest of the world. So 2 to 3 sentinel lymph nodes is a good recovery of sentinel lymph nodes. Next one. Next one. So you can see that we had identification rate of 97%. So in 97% of the patients, we could recover the proper lymph node, which was hot and or blue, or just blue but not hot. So and or hot and blue. And there was 13 patients in which the lymph node could not be identified, coming to a non-identification rate of just 2.9. This was high achievement of identification was possible because we wherever we had a problem, we called the lady who did the SCINTIMAMMOGRAPhy and was looked at the lymph node. Is it level 2 or is it deep or whatever, and we took her help in some cases. The next one. So you can see that even in this stage 1, where clinically the lymph nodes were negative, 80% of them, the lymph nodes were negative, and the axilla was also negative. So that means we had a true report in 80% where we did not need to do an axillary dissection. So see, 80% of the patients you can avoid doing an axillary dissection and preserving their shoulder, preserving their second intercostal, and preserving their arm lymphedema. Even in T2, so don't think that if the tumor is 4 cm and clinically if the node is negative, that 4 cm should have a node positive. That's not so. So in 70% of T2 tumors also we had lymph nodes negative. So just imagine 80% in T1, 70% in T2. So we could have avoided. This was a validation study, but now of course we are not dissecting the axilla if the sentinel lymph node is negative. So in 75% of T1 to T2 patients, we can prevent an axillary dissection and prevent all the disabilities and have a good quality of life. The next one. And again, if you see that 72.8% of the patients who had a positive sentinel lymph node had positivity only in the sentinel node, while the rest of the non-sentinel lymph nodes on axillary dissection were negative, meaning thereby that we are really picking up the right lymph node because that was the only positive lymph node and the rest of the axilla was negative. The next one. So the sensitivity was 96.7% and false negative rate was 3.3%, and this was the same as the rest of the world. The next slide. So we just compared our data on 218 patients, and these are the various other trials. So they had a identification rate of what we had, and the false negative rate in our series was even less than the rest of the data presented in the literature. Next one. So we're very confident of now doing a sentinel lymph nodes, and if it is negative, we do not dissect the axilla. If it is positive, then I'll just tell you what we do. So we have been able to, we've done another 200 patients with just sentinel lymph nodes in 2018, now many more. And you can see that the lymphedema prevention was in a large number of patients. Sensory loss, as I said, second intercostal brachial nerve, it doesn't come in our way when we do the sentinel lymph nodes, but it gets cut off when we do a when we do a axillary dissection. And shoulder disability, as preservation of shoulder disability in a large percentage of patients with sentinel lymph nodes, especially if the lymph nodes are negative and the rest of the axilla is negative. Why do you want to dissect it? And the incision is much smaller. There are no drains. There is very little seroma, and they go back to work with sentinel lymph nodes in 10 days time. Breast conservation with sentinel lymph nodes is 1.5 hour surgery or 1 hour surgery, and the patient is up and about the next day and is back to work in 10 days time. Next one. So in conclusion, it's a reliable staging with sentinel lymph. A reliable staging with sentinel lymph node depends on success of sentinel lymph node identification, low false negative rate, and histopathological accuracy. It saves a lot of morbidity, as you just saw, without compromising on overall survival and disease-free survival. So this was in 2018 when I said it's a safe, reliable, and effective procedure for staging. So in your center, if you don't have a nuclear medicine department, at least you can tell the surgeon to do it by a diet technique. Even the diet technique will pick up sentinel lymph nodes in 80 to 85% of the patients. So at least you can avoid doing axillary lymph nodes and keeping their quality of life intact. The next one. So now can we avoid, I think if it is lot of time, I'll go over the slides. I'll just run over them, or I'll just get the next one. This was a trial. The next slide, please. This was a trial called Z0011 study, as you all know about it. That in this one, they did a breast conservative surgery with sentinel lymph nodes with positive sentinel lymph nodes of 1 to 2, and they then randomized them at the time of surgery. If the lymph node was positive, either the patient underwent axillary dissection or the patient had no further surgery but had adjuvant radiation. Next one. And they found that those who had axillary dissection with a positive lymph node, or those who had sentinel lymph node without any extra radiation to the axilla, just radiation to the breast. So this was done in breast conservative surgery, where everybody received radiation to the breast. And I believe when you radiate the breast, level 1 lymph nodes in the axilla do come in the radiation field, and so level 1 do get the radiation. So there was no significant, statistically significant difference in the 10-year survival, whether you had axillary lymph node or sentinel lymph node, but all these patients are breast conservative surgery. We're not talking of mastectomy in this group. The next one. So, as you all know, that there's been some criticism to the fact that the radiation protocols were not adhered to. Lots of people, lots of radiation oncologists added a third field, and the third field they say was equal between the two groups, but one is not very sure of this. So whether you should radiate the axilla or not is a controversial point if there is only 1 to 2 lymph nodes involved, but you have not dissected the axilla. The next one. So the impact of Z001 trial, I just want you to see the last one in our country. We are saying that if sentinel lymph node shows micromets in 1 or 2 lymph nodes, who initially were reported as negative on frozen section but turn out to be positive on paraffin section, because 2 millimeter tumor cannot be seen well on a frozen section. So if it turns out to be positive, the patient does not have to go in again for axillary dissection, and they can be offered the radiation. They need not be taken back to the surgery. They can be offered radiation to the entire breast without radiation to the axilla. The next one. So I think we are running 1 hour already. There is also lymph node dissection in neoadjuvant chemotherapy. I told you that the breast conservative surgery can be done in neoadjuvant chemotherapy, but now we are also talking about lymph node, sentinel lymph nodes can be done in patients who receive neoadjuvant chemotherapy. The next one. Next one. Um, so the advantages of neoadjuvant chemotherapy, you all know, is that most tumors decrease in size by 40 to 50%, and there are lots of other advantages. The next slide. Um, so sentinel lymph node in neoadjuvant chemotherapy, it has become the standard of care in early stage breast cancer receiving post surgery, post surgery adjuvant chemotherapy. Um, in early stage, I mean, this is what we already discussed, but sentinel lymph node has recently been accepted in clinically node negative patients receiving neoadjuvant chemotherapy. So, if clinically and radiologically the lymph nodes are negative, like happens in triple negative and in HER2 positive, and we are giving neoadjuvant chemotherapy to even 2 cm and 3 cm tumors, then in that patient the sentinel lymph node post neoadjuvant chemotherapy can be done, has been done, and the results are equivalent to the group receiving no neoadjuvant chemotherapy. While axillary lymph node is still the standard of care for patients where the lymph nodes were positive before the neoadjuvant chemotherapy. Lots of studies are going on. We also doing a lot of studies on patients who were lymph node positive before the neoadjuvant chemotherapy, and they become lymph node negative post neoadjuvant chemotherapy. Can we do and sentinel lymph nodes to again give them a good quality of life? The next one. Next one. Um, let's see if there is controversy whether we should do it before or after. We'll leave it. The next slide. Next one. We the literature says, I'm talking of axilla where it's been positive, and then then sentinel lymph node has been done, and they have said that neoadjuvant chemotherapy reduces the lymph node involvement by 33% in one study, 40% in the other, and in T1 tumors, the axilla has been under downstage by 13%, and T3 tumor by 30%. Next one. Um, I think we'll leave this. There has been one study, as I said, if you have lymph node negative tumor, give me the last slide. If you have lymph node negative tumor and you're giving them neoadjuvant chemotherapy, you can do a sentinel lymph node, and the identification rate is better, is pretty good, and false negative rate is also less than 10%, so it is acceptable. But in node positive tumors, as I said, the studies are still going on. The next one. I think we'll leave the discussion. Next slide. Lots of studies. Next one. Next slide. Again, three studies are saying that in lymph node positive tumors, the false negative rate is more than 10%, which is not acceptable. The next one. So, lots of new trials are going on. Next one. And we have done this neoadjuvant chemotherapy in 98 patients. And next one, we found that um, that nodal stage positivity, nodal stage, sorry, there were a large number of patients in HER2 positive and triple negative group, and few patients in hormone receptor positive, because that is the one. Hormone receptor positive doesn't respond to chemo as well. And you can see over here, I just want to tell you our results, that if you give them a complete dosages, the one recommended dosages and the recommended neoadjuvant chemo, in HER2 positive, we had a pathological complete response of 61% in the lymph nodes. So if your node positive has become node negative in 61%, why should we be able to do a good sentinel lymph node? And if it's negative in our studies, we should not be dissecting the axilla. In triple negative also, there is a very good pathological. Again, this is by a multidisciplinary tumor approach, giving full dosages on time, patients taking it and patient being compliant. So there is a large percentage of patients having a complete pathological response rate. So this group of patients can be harnessed for a sentinel lymph node. Next one. Next one, I just wanted to tell you we done sentinel lymph node in 57 patients. We've been able to identify it in 47 patients, and our average number of lymph nodes were 3, and our false negative rate in node positive patients was 6.4%, which is very, very satisfying for us. And as we said, you are supposed to do it by double dye technique, and you are supposed to um, make sure that the lymph nodes have turned negative after neoadjuvant chemotherapy. The next one. So, this is the identification rate. As if it was N0 before, the identification rate was better. If it was N1 before, the identification rate was lower, because when it's N1, the lymphatics get sclerosed and the lymph nodes become so tiny and sclerosed that it's very difficult to find a sentinel lymph node. Next one. This is to tell you that our false negative rate was um, if one lymph node was dissected, the false negative rate was higher. If three lymph nodes were dissected, there was no false. So all false negative patients were in one where the lymph node was only one was dissected. So we are supposed to dissect 3 or more than 3 lymph nodes by a double dye technique, and that is what is a good sentinel lymph node in patients with post neoadjuvant chemotherapy. The next one. So in conclusions from our data of this one, as I said, that we are having a very good response, very good sentinel lymph node dissection with very low false negative rate. Next one. So this is all I have to tell you about sentinel lymph node. And again, sentinel lymph node is a valid option after neoadjuvant chemotherapy in patients with node negative and also node positive, given the high conversion rate, provided great care is taken in selecting suitable patients. Those with the highest possibility of nodal PCR, those with normal post neoadjuvant chemotherapy, ultrasound, CE, MRI, FDG uptake. I mean, where we do not see the lymph nodes on all these investigations, and sometimes we mark these lymph nodes, involved lymph nodes with clips. We do dual mapping. We try and take out more than 2 lymph nodes, and we think that if we enroll more patients in future, we should be able to conserve their quality of life and we should be able to do more of sentinel lymph node biopsies. And that's the end of my 1 hour lecture. I'm sorry I've taken a whole 1 hour, but if you have any questions, please do ask. We can stay back for another 10 minutes. Dr. Dodal, it's
Thank you
over
so much,
to you.
ma'am. Thank you so much for this excellent presentation and clearing a lot of confusions going on around sentinel dissection, whether to be done